Good evening, good afternoon, good morning, and we are right now live. Welcome to our Nephrocritical Care webinar number 3. And we are today discussing on extracorporeal therapy in sepsis, where we delve into the cutting edge nephrocritical care concepts. And today we are honored to have with us experts, I would say leading experts like Dr. Ramesh Venkatraman, who is a pioneer in extracorporeal therapy from India. He is a senior intensivist at Apollo Hospital, Chennai. And alongside with him, our distinguished panelists are Dr. K.R. Ramanathan, sir is from University Hospital, Singapore. And with him, I would also take the opportunity to welcome Dr. Sumit Ray. He is my teacher from Sir Gangaram Hospital, where I was trained as a fellow in critical care way back, I think around 12 years back. Not mine only, Dr. Sanant is also being trained under him. And he is the head of critical care as well as medical director of Holy Family Hospital, New Delhi. And Dr. Ghanshyam Jagatkar, who is because of some family emergency, is unable to join. He is the director critical care at Medicover Hospital, Hyderabad, India. So I also welcome Dr. Sanand Das, who is the facilitator as well as academic secretary from Nephrocritical Care Society from Australia. And Dr. Jacob Judge is the senior consultant and chairperson of ISCCM Kottayam, India. And he is also the organizing chairperson for our upcoming nephrocritical care review course, which is scheduled on April 27 and 28 at Kottayam. So we are thankful to all the attendees last time who expressed a lot of their thanks to all of us personally that that event, that webinar was very much successful, and we had a full house last time. And we also shared today the recording version of the webinar that was conducted on April 2nd, 2024 on newer targets of RRT by Dr. Valentine Lobo. So without wasting further time, I would now request the panelists to please introduce Dr. Ramesh Venkatraman, and please we'll be proceeding for the talk. And at the end of the talk, we are having a quiz, and this would be the second in line. And the significance of the second in line is we are having 4 quiz in 4 webinars this month, and the top 5 who would be securing the highest marks in the 4 quiz, they would be getting direct entry to the grand finale at Kottayam, where we would be having the nephrocritical care review course. Those candidates, those attendees who are joining online, but they are not joining in the Kottayam course, so we have special prizes for them that we would be couriering after end of the 4 webinar series. So with this, I am stopping my slideshow, and I am now handing over to Dr. Ramanathan, Dr. Sumit Ray, and the rest of the facilitators for the show.
So I think I'll just start off with by introducing Dr. Ramesh Venkatraman.
Yes, sir.
He's a senior intensivist with special interest in nephrocritical care, end of life, and many other aspects of critical care. He at Apollo Hospital, Chennai. Apollo Hospital has a deep lineup of great intensivists, and also Ramesh trained at the University of Pittsburgh in critical care and nephrocritical care. He has probably one of the best qualifications to speak about this topic. He has worked and done his research with John Kellum and the likes, who are the at the pole position of what would be called what is considered as nephrocritical care. So couldn't have asked for a better person to talk on this topic. So I would hand it over to Ramesh, if Dr. Ramanathan would like to speak a few words.
Thanks, Sumit. Nothing much to add, Sumit. I think, I'm also longing to listen to the talk from Ramesh. So I think we should get cracking. Thanks.
Right. Thank you.
Thank you, Sumit, for the nice words. Thank you, Dr. Ramanathan. Thanks, Jacob, Tapas, and Dr. Sananta for the kind invitation. Please let me know if you can start seeing my slides.
Yeah, it's all done. Yeah, you can just select the first slide. Yeah.
All right. Can you all see the slides now?
Yes,
sir.
yes.
Perfect. All right. Thank you. Perfect. Yeah. So thank you everybody for the opportunity. It's a pleasure to be part of such an elite group here, and congratulations to Tapas and team for doing a consistent work in this area, which is quite important for the trainees to get updated on. The next 30, 20, 25 minutes, I'm going to be talking about the principles of extracorporeal blood purification in sepsis. I will talk about the rationale, the mechanisms, the techniques that we have, the current evidence, and try to conclude with my perspectives on how I take the evidence. So this is just a simple slide, which basically gives you an overview of the inflammatory response that happened with any kind of stimulus, most common of which is sepsis, which is our area of interest today. As you can see, it's a cacophonic kind of a scenario where we really don't know what does what and then what triggers what else is happening. So over years, people have tried to block several of these molecules and see if we could improve outcomes in sepsis. And unfortunately, there are at least about 20 trials that have consistently failed to show that blocking any one of those markers is actually going to be improving outcome. There are several reasons for that. One, the inflammatory cascade is redundant. You try to block one, I think it takes an alternate pathway and goes and hits the target, number one. Number two, blocking one marker or one mediator could be potentially harmful because they may be combining with another mediator to do something potentially beneficial, and we really don't know how and what we are trying to do. So those two would be the main issue. And third, not all the markers, all the mediators are going to be up in the blood at the same time, and we really don't know what is the best time point to try and block one of those particular mediators. And this took about 2 decades of research for us to figure out that we are nowhere close to try to modulate the inflammatory response in sepsis. So then the question comes, okay, if I can't block a particular modulator or a mediator, can I just go and try to remove the mediators from the blood using extracorporeal therapy? For me to be able to use this technique in the bedside as a clinician, first, I need to know what I need to remove. 2, I need to know when I need to remove it and how long should I remove it before that inflammatory marker or mediator goes down. If I am able to remove it, how does it actually help in terms of the pathophysiology? And what are the techniques I can use to remove? And I need to be able to refine those techniques. And finally, does removing improve outcomes? I may be able to remove the mediators, but does it actually improve the outcomes? And final question as a clinician, I would say is, can I do it safely? So unless I'm able to answer all these questions with the current evidence, then I will not be able to use this therapy in real life. So let's just answer one question at a time. What should I remove? So I've simplified the first slide into a simple flow diagram. Obviously, it's kind of a rudimentary understanding of what we know about the inflammatory response. There is a trigger or a pathogen that basically comes, and there are pattern recognition receptors on leukocytes, neutrophils that kind of recognize the proteins that are exhibited by the pathogens that we called as pathogen-associated molecular patterns. And once they are recognized by these receptors, then the neutrophils get activated, monocytes get activated. They synthesize a lot of chemicals that we call cytokines. These cytokines go and hit some tissues and cells and damage them. And as a SOS signal, these cells basically, again, release some proteins that we call as DAMs, damage-associated molecular patterns. And they are again recognized by these pattern-recognized receptors in the neutrophils and monocytes. And that again triggers further signals and amplifies this immune response that goes. So our potential thought process would be, 1, we should be able to remove the pathogen. 2, we should be able to remove the PAMP, which is the protein-associated molecular pattern, a common example of which would be endotoxin. 3, if we can do something to the neutrophils or monocytes and modulate the way they behave, that would be good. 4, can we remove the cytokines, therefore preventing damage? And 5, can we actually remove the DAMs, the damage-associated molecular patterns, which again go and further augment the inflammatory response and do a lot of damage to our host cells. So simplistically, these are all the targets that we can potentially go after, and that's how the technology has evolved over a period of time. The question is, when should I remove? It's $1 million question. This is exactly what happens in sepsis. There is an infective insult that happens. Immediately, there is a pro-inflammatory arm that keeps going up and a slight lag, but then subsequently, there is also a whole bunch of anti-inflammatory molecules that keep going up. The pro-inflammatory comes down early, the anti-inflammatory stays a little bit longer and leads to immunoparalysis. So if you do it too early, we probably hurt everything. If you do it too late, we will be removing the anti-inflammatory molecules. So we have to be doing it right in the middle, which is the zone B, where all the inflammatory modulators are at a very, very high level. The trick in real life is to know when these levels are high and how we can go about taking them off. So the next question then is, okay, if by some mechanism I'm able to remove these mediators, how will they help? Again, there are several hypotheses that have been put forth by experts. The most common one is the peak concentration hypothesis. So there are several mediators that reach a peak and trough. And at some point, we are doing some kind of a non-specific removal of mediators that you kind of truncate the peak. The overall peak comes down. And because of that, the severity goes down. And therefore, hopefully, the inflammatory cascade gets turned off. But the problem then is, most of the time, most of the research has shown that even with these extracorporeal therapies, we make very, very little impact on the plasma levels of these immune mediators. So then how does this theory work? People argue that it probably works because we remove from plasma whatever is there in the interstitium and tissues move back into the plasma. Therefore, you may actually not see decreased levels in the plasma, but then you're still truncating the overall amplitude of the inflammatory response. The second pathway is that, yes, I'm removing from the tissue. By removing from the tissue, somehow I'm actually getting the inflammatory markers out of the interstitium, out of the tissues, and I'm coming down here. The question is, how am I removing it from the interstitium? And that's a question that we don't know. There is some evidence to say that when you use high volume hemofiltration, you increase the lymphatic flow by almost 10 to 20 times. And when you do that, there is possibility that the mediator level at the interstitium is being dragged into the intravascular volume, and subsequently that can be removed by whatever technique we use. And at last, what people have found that is, by doing all this, we change the concentration gradient of cytokines between the injured tissues and the blood, and this favorably modulates the neutrophil functions, where there is more neutrophils and less cytokines at the tissue level trying to protect the tissue. And again, this is what people would call it as a cytokinetic model. So there are several mechanisms that are attributed to the various techniques we use. They all make logical sense. We really don't know if one or more of those mechanisms are actually happening at the bedside. So the first thing is, we kind of know what we need to remove. The timing is kind of tricky. We have potential mechanisms of how it can help. Now the question is, how can I remove it? The first obvious technique is, can I just do dialysis and then try to remove these inflammatory markers? As you all know, if I'm going to review molecules from the blood, which is solute, I either use convection or diffusion. Convection is using a transmembrane pressure across a membrane and trying to push the solvent and use the solvent drag to remove the solutes. Diffusion is just passive movement of solutes across the semi-permeable membrane based on a concentration-dependent gradient. Clearly, diffusive clearance is very good for small molecules. Convective clearance is good for middle molecules and high molecules. I want to tell you here is 1,000 means 1 kilodalton, 10,000 means 10 kilodaltons. But now let's see where cytokines are actually positioned. Urea and creatinine have a molecular weight between 10 and 100. Cytokines, the earliest ones, IL-1, TNF, and beta-2 microglobulin, have a molecular weight of at least about 60 kilodaltons. And we are talking about several times higher than what a normal dialysis filter can actually do to try and remove these mediators. So this is a nice paper from 1999 that actually looked at, can inflammatory cytokines be removed efficiently by CRRT? Basically, they ran CRRT over a period of time. They measured serial cytokine levels. They also found a mechanism to say how much was removed by ultrafiltration and how much was removed by adsorption, adsorption on the membrane itself. They change the filter every 12 hours in the study. As you can see, as time goes on, the removal rate goes down, and you can see that adsorption is the shaded portion, is the predominant mechanism of removal of cytokines and not convection. There is absolutely very negligible or non-existent removal in diffusion. As you saw earlier, diffusion is not good in removing high molecular weight substances. Therefore, diffusion does not come into play. Convection can be of some help, but predominantly it's going to be adsorption that is primarily removing the cytokines. So we kind of know what we need to do to remove these cytokines. So conventional membranes usually have a pore size of 5 nanometer. Their cutoff is 30 to 60 kilodaltons maximum. But remember that most inflammatory cytokines start at 60 kilodaltons. Therefore, our efficiency of removal may not be very good. Diffusion, absolutely useless unless you add a little bit of filtration to it. But again, that has its own limitations. Convection, we can do the conventional hemofiltration that we would do for acute kidney injury, but probably the amount of solvent drag you need for removing inflammatory markers will be much more, that the conventional hemofiltration is probably not a good idea. So I need to increase the hemofiltration much more for me to be able to remove the inflammatory markers. Or the last option would be to make membranes that are hugely porous, so that high molecular weight substances can easily come through those membranes and get removed. And that's what we would call as a high cutoff membrane. And finally, the most important mechanism for us to be removing inflammatory markers would be adsorption. And there are several adsorbent filters available in the market that have tried to do this. So in summary, we can either do it by convection, which is conventional CRRT, high volume or a very high dose hemofiltration, open membranes, which are high cutoff membranes, adsorption filters. We can combine therapies like coupled plasma filtration or adsorption, or a filter that can do it all, which we would talk about later in this talk. So, as you all know, when I do CRRT for acute kidney injury, the dose that has been shown to be effective is 25 ml per kilo per hour in CRRT post-membrane dilution. But above 25, really, we do not have a survival benefit. So people said that, okay, if I need to do AKI support, 25 is good. But as I said, if I have to remove mediators from the blood, probably the amount of dose I need to give is much higher, so that I can remove these high molecular weight substances. And people hypothesize that I would probably need somewhere at the range of 50 to 70 ml per kilo per hour as the dose that would be necessary to do appropriate blood purification. So this has been evaluated in one of the largest studies. I mean, I'm just quoting the most important studies for each of the technique for sake of time. This is the IVOR study, where they randomized patients, in about 140 patients, to 35 ml per kilo per hour, which is considered as the high end of normal CRRT that you would do, versus 70, almost doubling the dose. And they did high volume hemofiltration for at least 96 hours. And the transmembrane pressure that they had to apply is 100 to 300, which is humongous. And unfortunately, they had to stop the study in between because there was no mortality difference between the two groups at the interim analysis, and they had to wait. There seemed to be some physiological benefit, but clearly, in terms of mortality, there was no difference between the two groups. There is a meta-analysis that has combined all the studies that have been involved in high volume hemofiltration, clearly showing that the relative risk is no different between the groups that got HF versus control. And their conclusion is there is weak evidence to support the use of high volume hemofiltration in critically ill patients with septic shock to improve outcomes at this point of time. Just doing them has several practical implications. First and foremost, I need such a high blood flow, but I also need to keep my filtration fraction less than 25%. If it's more than 25%, I am going to be causing a lot of protein caking and saturating the membrane very quickly. And to maintain such high flows, I probably need a huge vascular access that I need to be careful about. I need a large amounts of replacement fluid. It has to be bicarbonate base. I need to be able to do it both pre and post dilution, so that I don't cause huge changes in filtration fraction or compensate or compromise on the dose of the filtration that I do. I need to use a highly biocompatible synthetic membrane with a large surface area. We're talking about a surface area of almost 2 meters square, and that's the kind of membranes you would need. And finally, all of us know that even simple CRRT causes profound hypothermia. You could imagine that when I do high volume hemofiltration, I need a mechanism to heat the replacement fluid and blood to maintain euthermia in these patients. And so people said, if I can't do for 4 days, can I do pulse therapy for 6 to 8 days? And people have said, okay, if I'm going to do pulse therapy, can I do it at a much higher doses? So people have actually tried 85 ml per kilo per hour for 6 to 8 hours, but unfortunately the results have been mixed. The problems with high volume hemofiltration are we're going to remove everything, including large molecular weight substances, which means a lot of low molecular weight molecules will come out. We get profound hypophosphatemia, hypokalemia, vitamins, trace elements are all removed. We cause hypothermia to the point where detecting infection is going to become a problem. So when somebody gets actually septic or the patient is already septic, there is no mechanism for us to try and pick whether they're getting worse or not based on their temperatures. Antibiotic dosing, this has been one of the commonest criticisms about high volume hemofiltration, that we remove the antibiotic we give, and we know that antibiotic is one thing that improves survival in these patients. And if you remove the antibiotic and we do not know how much to give back to maintain therapeutic levels, we are bound to cause harm in these patients. Cost is going to be huge in our country, nursing workload. And for all those reasons, people have tried cascade hemofiltration where they have used 2 filters, one to filter the plasma and then do high volume through the other one and then circulate it back to the patients. But it's again getting too complex to try to achieve our ends that it's probably been given up many years ago. So if I cannot increase the dose of hemofiltration, can I just open the membrane? I've just given you an electron microscopic picture of the various membrane. This is a high flux dialysis membrane. So it's actually a quite permeable membrane, but the pore size is 0.01. For high cutoff, you're talking about doubling the pore size. You can see that the pores are now visible. If you're going to do protein separation or albumin dialysis, you're going to need a much, much more porous membrane. Finally, the plasma filtration or plasma exchange we do, it looks like craters on a surface of a moon. So that's the kind of pore size we are talking about. Here, we are talking about high cutoff membranes, which have a pore size double of what an average dialysis membrane is, so that the large molecules can easily come even with the conventional dose of hemofiltration. And most of the studies that have done high cutoff membrane dialysis have used only 25 to 35 ml per kilo per hour as their dose and looked at effective removal of mediators. The biggest study is the high-cost study, where the primary endpoint was norepinephrine requirement, ventilation, and the secondary endpoint was 28-day mortality. Unfortunately, the study did not show benefit at the interim analysis, and this study had to be stopped. Again, the problem is the loss of albumin in these membranes is almost 15 grams in 4 hours of treatment. And you can imagine the amount of antibiotics and other things that are lost, like high volume hemofiltration, that we are actually not too different in terms of what we are going to be removing, and we probably potentially are capable of causing significant amounts of harm. If I can't do high volume hemofiltration, I can't do high cutoff membranes, can I use the most efficient mechanism to remove mediators, which would be adsorption based on the 1999 study I showed you? And people have said, okay, can I just use non-specific adsorbents to attract solute through a variety of forces? They can engineer the adsorbents to change the pore size. They can coat the adsorbents with various materials so that it can have affinity to various molecules that we want. And there's a huge surface area. We will talk about the surface area of adsorption filters when I show you an example. We talk about it. And we know that this is the most important mechanism of cytokine clearance. So why not we use it? And over years, we have gotten better in terms of making these adsorption filters with increasing biocompatibility so that we don't necessarily trigger an inflammatory response just because of letting blood perfuse through these adsorption filters. Most of these adsorption filters are variations. Either they have discs or spheres with multiple pores with a huge surface area. We are talking about a surface area of 40 to 45,000 square meters compared to 2 square meter in a high flux dialysis membrane that we talked about earlier. And this surface is either modified by several forces, for example, ionic forces, hydrophobic forces, electrostatic forces, or van der Waals forces, or they coat them with various resins or molecules so that they have selective or non-selective affinity to a large number of molecules. Here, the molecular weight and the pore size would determine what is getting adsorbed and what gets released back in the blood. So over years, hemoadsorption devices have been developed for several things. We talked about adsorption devices for pathogens, the Seraph filter, which is not available in India at this point of time. It is currently experimentally used in other countries. Dams, the classic example of PAM is actually endotoxin and LPS. We have two filters for PAM. One is the polymyxin filter, other is the LPS filter. Then for cytokines, we have a non-selective adsorption through cytosorb or Jafran. So there are several filters now made for all the molecules that we talked about in the pathophysiology of sepsis. So one of the first filters that came in terms of data-wise was the polymyxin filter, specifically adsorbing endotoxin. This is the first major study, the UFAS study, where they looked at about 60 patients with only abdominal sepsis. The primary outcomes was only physiological, hemodynamics and oxygenation. Secondary outcome was mortality benefit. They did show significant improvement in mortality with this filter in patients with abdominal sepsis who probably needed surgery. There are a few criticisms of the study. The first one is the control group had very high mortality for abdominal sepsis. Number two, if one patient had died more in either of the groups, the study would have become non-existent. So that was one more criticism. It was kind of a weak positive kind of a study. And the last one was there was no protocolized titration of vasopressors. When you have a primary outcome of hemodynamics and you do not protocolize how you manage your vasopressors, there could be intrinsic bias in how these patients were managed. And those were the criticisms. Because of this, the next study was done. This is a multi-center study done in France, looking at, again, the polymyxin filter in patients with abdominal sepsis and septic shock. They actually enrolled 243 patients, and their primary outcome was 28-day mortality. In this group, in this study, there was no difference between the polymyxin group and the control group. Here you can see that the control group mortality was only 20%, much lower than the previous study. One of the biggest confounding factors of this study was only 70% of the patients in the polymyxin group were able to get both the treatments. That the filter was used twice, each time at least for 2 hours, and only about 2/3 of the patients were able to get both the treatment. So the compliance in the treatment was probably not good, and that was probably used as an explanation of why this was a negative study compared to the previous study. The last significant study is the Euphrates study, where they looked at all comers with septic shock. The previous two studies were only abdominal sepsis. Here they said that I am going to do an endotoxin level and pick patients only with endotoxin level that is at least reasonably high. They picked a cutoff of more than 0.6. If their endotoxin level is less than 0.6, probably the levels are not high enough for you to put an extracorporeal therapy, and that's how they started. Over time, they realized that if the MOD score was more than 9, those patients seemed to be doing better, and they changed the inclusion criteria to do that. And the original analysis showed that there was no difference in survival between the treatment group and the control group. However, in subgroup analysis, they found that if you had an endotoxin level between 0.6 to 0.89, then you had the maximum benefit, and there was a survival benefit in that group. So if your endotoxin level was very low, probably you don't need the filter. If the endotoxin level is too high, above 0.9, probably doesn't matter what you do. Those patients are really sick, and anyway, they're going to die. It kind of makes sense that you would probably, any therapy would probably work in the intermediate group, and that's pretty much what the subgroup analysis showed in this Euphrates study. Several meta-analyses have looked at it, both in abdominal sepsis and in all sepsis. Unfortunately, when you combine all the data, there is no significant outcome benefit in terms of survival. So rather than targeting only endotoxin, which is predominantly present in all gram negatives and about 50% of gram positives, can I just go and non-selectively absorb all the cytokines available in the blood and hope that I can make an impact? And this filter was created for that. This is the cytosorb filter. It absorbs a whole bunch of things between molecular weights of 5 to 60 or 65 kilodaltons. And this is the range of molecules that this can probably non-selectively absorb over a period of time. There are several small studies. No major randomized control studies have looked at. I've picked the most recent systematic review and meta-analysis that looked at all subgroups in which cytosorb was particularly used. When he looked at all patients, no survival benefit. Sepsis alone, no survival benefit. Post-cardiopulmonary bypass, no survival benefit. Any other severe illness, no survival benefit. COVID, no survival benefit. Post-cardiac arrest stated this inflammatory response. In fact, it showed harm. So they have looked at every subgroup, and clearly there is no benefit with cytosorb based on the current evidence. This paper basically said if you put cytosorb to a non-selective kind of patients, you're unlikely to find any kind of benefit. Why don't we use it in somebody who probably needs it the most? They came up with an arbitrary score called the cytoscore, where they looked at the lactate clearance, the rate of change of norepinephrine, whether hydrocortisone used, how much fluid bolus was used between the first hour and the 6th hour. And then they created the scoring system, and they stratified patients based on the scoring system, and retrospectively went and looked at all patients who got cytosorb versus not, and showed that in patients who probably meet certain criteria, if you started very early, within 12 to 24 hours, there seems to be a benefit. Again, this has to be validated because all these variables were picked arbitrarily without any validation. It has never been cross-validated in a huge database. It is only retrospective data. We probably need to use some kind of stratification before we actually say whether this is going to work or not. What about combining two options? You do plasma filtration first and then do the adsorption filter. This is original paper from Ronco, where he did the rabbit studies and then subsequently went on to patient studies. The first study showed some physiological benefits. The second study, the Compact 1 did not show any survival benefit. The Compact 2 actually showed worsened survival in patients with CPFA, to the point where study was terminated. An email was sent to every investigator and every clinician using this technique in Europe to say, please do not use this because it increases survival in patients with septic shock. So in summary, talking about the various main studies in extracorporeal blood purification, IVOR study for high volume hemofiltration, physiological benefit, no mortality benefit. Polymyxin filter, 3 studies, the UFAS and Abdomix looked at abdominal sepsis. UFAS showed mortality benefit. Abdomix did not show any mortality benefit. Euphrates showed mortality benefit only in a subgroup where the endotoxin level was in the intermediary range in a post-hoc analysis. Cytosorb, in fact, showed excess mortality. The largest randomized control trial showed excess mortality. I will talk about it a little bit later. CPFA basically showing that no mortality benefit. The most recent CPFA study showed worsening survival in patients with CPFA, and therefore the study was stopped. So we need to understand that most studies not only do not show mortality difference, there are studies that show increased mortality, and we need to be wary about using these technologies blindly without paying more attention to it. Can I put everything into one approach and probably try and do something? Do convection, do adsorption, do endotoxin absorption, do cytotoxin absorption. So this is a new filter which has been over a period of time developed from the original AN69 high flux membrane, where they have coated this filter with 3 different layers. The inner layer has a hydrogel structure which absorbs cytokines, and you can also do convection and has a cutoff of at least up to 40 kilodalton. The middle layer seems to be can absorb endotoxins, and the final layer is heparin coated so that it does not cause any thrombogenesis. So this is one filter where it achieves 4 purposes. You can do convection, you can do adsorption of cytokines, you can do adsorption of endotoxins, and also probably negates the need of any heparin or anticoagulation seriously ill patients. There are several small studies that are doing with this filter. There is a recent meta-analysis that has been published that seems to suggest that there may be a benefit. There are several criticisms of this meta-analysis, which I'm not going to go into, but the data seems promising, but we need to look at the number of patients in each of the studies. It's extremely small. The total patients is only 229. So we need to be careful of making decisions based on this one meta-analysis. So this is the meta-analysis on plasma exchange, just taking the plasma out, for whatever it's there, you remove, you give new plasma. So whatever benefit the new plasma can have, can do that. There are 2 major meta-analyses. Both of them have shown kind of a lukewarm response with a lot of heterogeneity in studies and weak positive kind of a results with plasma exchange in patients with septic shock. The last important question as a clinician is, can I do it safely? In the last 4 years, we have had several papers that have shown harm with adsorption filters. This is the Compact 2 study where I clearly told you that the CPFA mortality was much worse than the control mortality. This is the largest randomized controlled trial with cytosorb published in 2017 or 18, showing worsening survival with non-specific cytokine adsorption using cytosorb versus controls. There is a recent systematic review and meta-analysis on harm and adverse events with heme adsorption, clearly showing that the mortality, the serious adverse events and adverse events are much higher in patients where cytosol was used across studies. And this needs to be carefully pondered about. And then now people have started writing about the possible mechanisms of how adsorption can actually be harmful. The one easy mechanism we could probably say is removal of antibiotics, but there are several mechanisms people are trying to explore to understand why adsorption can potentially adversely worsen the survival. So Surveying Sepsis Guideline 2021, looking at the evidence, basically said that there is insufficient evidence to make recommendation on any kind of blood purification technique. Even for polymyxin, they said that we do not recommend it routinely at this point of time. So where are we now with extracorporeal blood purification? To answer the questions, mediator removal is feasible. When I remove mediators, I do have physiological improvement, but I seem to cause collateral damage, which I do not understand it very clearly yet, and there can be potential harm. High volume hemofiltration and high cutoff hemodynamic benefits, very good randomized control studies stopped in middle for no survival benefit. Heme adsorption, data is strongest for the polymyxin heme adsorption. Consider it if MOD score is more than 9 and if you have access to endotoxin level, and if it's between 0.6 to 0.9, those patients would probably benefit. Apply it early, probably within 24 hours of resuscitated shock. Non-specific cytokine adsorption or coupled plasma filtration adsorption at this point of time, I probably would stay away purely because there is trend towards an increase in mortality in those patients. Oxidase filter seems to be promising based on the meta-analysis, but we are going to need more data before we could routinely say we can use it as a standard of care. So when should you consider extracorporeal blood purification in sepsis? If a patient has refractory shock, I've already done adequate resuscitation, hemodynamic optimization, control the source, given appropriate antibiotics. All this has happened between hour number 1 and probably hour number 12 realistically, and the patient is still deteriorating or has got a life-threatening shock, maybe consider at that point of time. If I have access to endotoxin level, and if the level is between 0.6 to 0.89, I would go with polymyxin filter. If my endotoxin level is not available, or if the patient anyway needs renal replacement therapy, I would probably start oxidase filters, but very clearly counsel the family that is experimental and document and probably get consent for this. You could argue that it's probably a part of CRRT and probably get away with it, but I would say it's clearly experimental at this point of time. So what is the way forward? Should we just throw away extracorporeal blood purification? It doesn't work. What should we do? I'm going to argue that we have evolved in terms of lung protection over a period of time. We thought low tidal volumes were good. Then we said, no, it's the low plateau pressure. Then we said, keep the lung open. Then we said, oh, no, it's the driving pressure. It's not the tidal volume or PEEP. Then we said, no, it's not the driving pressure. It's the power. Then we said it's a driving power. Now we say it's a cumulative injurious strain that we can give to the lung. And over years, we have probably refined our understanding of both how we should do correctly and what potentially causes harm in these patients. And I would argue that we need to learn to perform good extracorporeal blood purification. We are still primitive in the way we understand. We do not know which patients to select. We do not know which device to be used at what time. We do not know how to dose the therapy. We do not know how to customize the technique to the particular disease or the individual. And then we need to understand how to dose drugs, especially antibiotics. Mainly, more importantly, understand mechanisms of harm and stay away from that, and hopefully get more proof of good outcome over the next few years so that we can use this therapy in patients with septic shock and improve their survival. Thank you very much for your attention and time. Thank you.
Thank you, Dr. Venkatraman, sir. It was truly captivating, I can say only in one word. So now I would request our esteemed panelists, to please share their valuable experience as well as expertise about this important concept.
Thanks, Tapas. It was an excellent talk, Dr. Ramesh. Clearly, you outlined the different kind of techniques, the evidence for it, and where we stand. One thing that always intrigues me is, despite multiple failures in this domain of treatment for septic shock, we still continue and persevere to find that right combination, the right time, and the right patient. And so far we've not been successful, and there have been a lot of ifs and buts. And I always wondered whether when we use these purification techniques, I agree mortality is a big thing in septic shock, but then whether that should always, whether that should be the endpoint for measurement in terms of how we manage refractory septic shock. Clearly, once you hit that threshold, the mortality is always going to be high. I think as a clinician by the bedside, I would want to stabilize my patient further. And in that context, if this is going to be used in refractory septic shock, should we be using a different endpoint here rather than mortality or other hardcore, clinical outcomes? Say something like reduction in vasopressor score or something like that. That would enhance the use of such devices. Of course, a few of the devices you highlighted do cause harm. So at this point of time, those devices may not be at least evidence-based if you're going to use it on your patient. But there are a few devices that have clearly shown improvement in hemodynamic support, and whether when you're pushed against the wall and you're cornered and your patient is dying under your nose, whether we should look at some of the other options, say high volume hemofiltration or HCO, in the context to cut down the vasopressors that we go on. Again, these are thoughts. There are no definitive answers, I believe, and clearly, when we believe that evidence comes from randomized controlled trials, we also need to consider the fact that RCTs get powered to measure a particular outcome, and some of the secondary outcomes that show significance may not be measured, but that might be valuable to the bedside clinician. Yeah, I mean, these are my thoughts. I'm sure, I would like to know your comments on that aspect.
So valid thoughts. I agree with you that vasopressor requirements are probably a good surrogate to use. My concern comes that in most of the trials where they have shown vasopressor decreasing, they have not standardized the way the vasopressor. So there's a lot of bias. And my concern is, one end, yes, I can show vasopressors decreasing or IL-6 decreasing or some physiological benefit. On the other hand, I don't even know how to do dose antibiotics, which I would say is a fundamental thing. We'll be practical about it. Most people will say, okay, do therapeutic drug level monitoring. How many drugs can you monitor? In a situation like in India, where we are having resistant bugs, I already don't know whether I'm actually giving the right dose for a particular patient with all the limitations that we have in the ICU. On top of it, you have high volume hemofiltration or high cutoff, and I'm removing. In fact, I would say that there are very good data to say that the dose of analgesics goes up with a lot of these techniques. People have shown that sedation is not removed, but analgesia is removed, and patients need higher analgesia after you do these kinds of therapies. So my concern is, without understanding holistically what we are doing, should I just chase a particular technology only because it decreases pressors in a case series where or in small trials where the vasopressor management has not been standardized? To me, I feel I would probably be uncomfortable if such a therapy was offered to me.
But if I can also put in my thoughts on this one. Am I audible?
Yes.
Yeah. So Ramesh, as usual, fantastic talk and a very balanced view. So the fundamental question of why they do not work, I think some of the fundamental question is the inflammatory response itself. It is, we have to realize, a necessary evil. It is a necessary evil which goes out of control to a certain extent, but it still remains necessary for clearance of the infective organism from the system. The second is, and this is one is based on my, trying to study these things for a while, and also having done an ICMR project, which we published of about 180 odd patients. What we found was that the deaths from the pro-inflammatory cytokine response as we have learned to manage it better and better, even this is nothing to do with cytokine removal, was very low. And early deaths in sepsis was getting lower and lower in our usual standard of care managements that we were practicing. What we found was the deaths were higher much later, and in those who had a predominantly anti-inflammatory response. But it's a difficult one to kind of find out from just the cytokines, but from also the monocyte HLA DR expression is also an important way to look at it. So what we found is actually the mortality that happens was happening much later from sepsis, because we were able to manage with the standards of care, even without cytokine removal systems, etc., quite well. So in the subset of patients, as Dr. Ramanathan said, that doing using these to reduce vasopressors seemed to help to improve flow, but in outcomes it would not, because what was happening is there was a second hit in most of these patients who died, who had the anti-inflammatory dominance or in higher expression of HLA-DR expression. There was a second hit between day 4 and day 6, which was related to the cytokine, the patterns of the cytokine. And these patients died much later. The mean day of death was day 16, which was very different from what we used to see 25 years earlier when I started out in critical care. So that is why the two elements which probably are a reason why this doesn't work like all other immune suppressive therapy is that, one, the inflammatory response, for all its faults, is a necessary evil, which you need for removal of the organism which has triggered the infection, triggered the problem. And the second is our standardized care in the beginning, in the early phases of sepsis, usually has become fairly good, and outcomes in early mortality has reduced significantly. But if we remove these cytokines, which are and the third thing, I think, is once we remove these cytokines, as what you touched upon, Ramesh, is that what is happening to the release from the other side? We are removing it from the intravascular space. How are the shifts happening in these cytokines from the intercellular space and the interstitium? That's also a challenge, which is what is probably, this balance is also what is affecting the outcome. And that's why probably these removal methods have not been of much value, and harm probably also because of the fact, as you rightly said, both of you rightly said, that removal of antibiotics, dosing of antibiotics, if we are not being able to achieve proper dosing of antibiotics in a really sick patient, that would cause harm, whatever your cytokine levels are going to be. That's my long two-bit.
Great thoughts, Sumit. I mean, that again makes me wonder, and I'm sure, I'd like to pick both your brains on this, and whether this entire purification technique would work at all. I mean, clearly there are some theoretical benefits which we claim, and we know that whenever we talk about these pathophysiological mechanisms and counter them in a logical way, there have been clinical instances where it has not been successful. Is this one of those therapies that has, say, no light at the end of the tunnel, or is it a kind of a technique that is still waiting for that right patient to be used on? So we probably, as you rightly said, we are either using it, the timing of the device is probably not right, and it's not getting used appropriately. So does that mean that this devices may not work at all, given the evidences we have accrued so far?
So one possibility, but also I think this is where probably large data analysis leading to precision medicine, the subphenotypes which can be picked up, possibly could be of help. And it will require huge amounts of data to go through data analytics to find out probably the subset and and the heterogeneity effect that is there, and pick up the subset on which we need to do the study. Possibly, I personally, in a sense, at this present moment, I would agree with you, Dr. Ramanathan, that probably not beneficial, but I would, if one needs to be scientific, probably one should leave the question partly open always, that research needs to be done, and probably subphenotype. If I was, if 20 years back, I would have said absolutely no when I was younger, but I'm probably hopefully wiser and older. So I would say that possibly the subphenotypes which could benefit have to be picked up with large data. And this is where, not in your caregiving, but in your research and your subphenotype detection is where AI, everybody talks about AI now. I'm not seduced by AI by itself. It is going to be part of our lives, but it is that subphenotype, which is AI is going to help us pick up, may or may not be find a subset. So a subphenotype which can respond, for which it can be useful. So that's where I would put it at this present moment. I mean, and Sanant, Tapas, you are also experts on these. You can put your 2 words in. We are not the only experts. We are all kind of shooting partly in the dark.
I was a bit curious about your 140 patients that you do the ICMR
Yes.
project.
Right.
How many were there neutropenic sepsis where I know the
Yeah, so none of them, because we were picking up patients. The criteria at that time, because it was done fairly early, was we were looking at the inflammatory response. The SIRS response was part of the definition of sepsis. So what we interestingly found was that a fairly large number of patients had a predominant anti-inflammatory response fairly early in their sepsis, fairly early. And now it is, many studies have shown that, right? That it starts earlier. It was that one follows the other. But when we did that, that was the predominant thought, the Hotchkiss's classic diagram. But not just us, many people have found that it almost in many patients, it happens almost simultaneously, a lag time maybe of a few hours only. And those who had a predominantly, we looked at the interleukin 1-6, TNF alpha on the inflammatory side, and the anti-inflammatory IL-10, IL-1 receptor antagonist. And we found that those who had a predominant anti-inflammatory response actually were dying more. They did not die in the first. So if you did a target mortality which was less than 30 days, right, 28 day, 30 day, you may not get to see that much of a difference. But when you are doing it longer, at 14 days, which many of these cytokine studies did, the cytosop studies, etc., did, there would be no difference, because most of the mortality in this subset was happening beyond 15, 16 days. So at 30 days, you would start seeing the difference in mortality. So these were not neutropenic patients. None of them oncology patients, non-neutropenic patients, actually fulfilled the full SIRS criteria. And also a small, we didn't have the money. Actually, we had pitched the money for the cytokines, but my future study, and I have not been able to do it, is to look at the monocyte HLA-DR expression, which is a very interesting model that, studies that have already been done and quite interesting data coming out. How do we intervene? Yes, we will find something, but how do we intervene is the big question, because nobody seems to know what to do with it. Yes, people have found out that the expression, monocyte HLA-DR expression, is an important factor which will tell us that these patients are going to die. But what do we do for it? Do we give GM-CSF? Do we give immunostimulants? Obviously, that is going to be counterproductive. So those are the thoughts. So for a long, long time, I have been somebody who has been looking at the anti-inflammatory response more than the pro-inflammatory response, actually.
So that's one of the problems, right? We remove the anti-inflammatory stuff too. So
Yes.
we don't know.
Yeah. And also, the anti-inflammatory surges keep happening also much later. So you do the cytosort for two times or 3 times, okay, in the initial phase, right? You remove the pro-inflammatory, and after that, you are not checking what is happening to the anti-inflammatory. It keeps getting released. So you may have a predominant anti-inflammatory because you have removed most of the pro-inflammatory initially. That could also be a reason. And that you have deaths much later, right? And you get a second hit because of the predominant anti-inflammatory, and so second hit sepsis. What Hotchkiss's data also showed, ours also matched exactly. We used to get the second hit in this subset between day 5 and day 7. Hotchkiss's studies showed between day 4 and day 6. So it's very, very interesting what we couldn't publish it in a very good journal. Critical Care, we got, it was like a correspondence that we got. It was just a 1-page thing that we got there. And this was long back, and obviously India was not kind of recognized to be doing this kind of work. So at that time,
A follow-up, Sumit, we just look clinically at all patients to our ICU who
right,
are originally admitted with sepsis versus
Right.
non-septic admissions. And we look at the incidence of secondary infections.
right,
Just, we couldn't do molecular stuff, just I thought
Right.
clinically. We actually found, obviously, that patients who were admitted originally with sepsis had a much higher incidence of hospital-acquired infections. Like you say, the second hit happens much more than a patient getting admitted for a GI bleed or a stroke or
absolutely.
a myasthenic crisis or something like that. And one center study, small cohorts of maybe 200, 300 patients, but still, like you said, we don't understand what happens, how long it
And
happens.
look at the timeline. Look at the dates. I mean, days and that. You will see it's very typical. It will be about day 4 to day 6. If you go back to your data, just analyze that. It's so typical that it's almost like there is a pattern set into it. It was very surprising that all the data showed that kind of a hit between that day 4, day 6 kind of hit. So it was very, very interesting. I mean, I learned a lot just doing it. I could not publish it very well, but yeah, while looking at it.
Yeah, so very exciting discussion. I can say, brainstorming as well. So, if given a chance, Dr. Sumit, Dr. Ramesh, as well as Dr. Ramanathan and Dr. Sanant, what should be the way forward? Like, if we have been given a chance to propose a RCT, so what should be the way forward? Because it's like we know that it is theoretically appealing, but practically still now disappointing results till now. Like most of the trials that have shown not to be very impressive results. So what we can do in future? Anything? Any thoughts on this?
I'd give up the difficult questions to Ramesh and Ramanathan and Ramanathan. But
That's
then
being
please
cheeky.
go ahead. Your thoughts.
No,
Sorry.
The things that we could consider is see if we can identify. Dr. Sumit talked about biological phenotypes in terms of how the cytokines behave and what patterns, and he said that there is a consistent pattern for people who develop a second hit. If somehow there is a way for us to pick the clinical phenotype, because not all of us are going to be able to do that, but if there are some clinical characteristics that we can pick as a clinical phenotype in that kind of subgroup where we feel that this is likely to happen, maybe offering that therapy to those people would be helpful. Oxiris seems promising. We don't need any further biomarkers at this point of time. Most patients with septic shock, almost 40% of them anyway need probably some form of RRT. In those patients right now, I would probably, if the cost differential in India is something that we need to account for, but if they are okay, I don't mind throwing in Oxiris filter at least for the first 48, 72 hours till they're, like they say, cool off, hemodynamics get better. Then if the cost is in factor, go to conventional RRT is something I think most of us would feel is reasonably logical at this point, considering there is no definite signal of harm. It may or may not benefit. There is reasonable rationale and mechanisms involved. So I wouldn't mind doing it. Maybe I'm sure there's a much larger study coming with Oxiris with randomized control trial at some point of time. Seems like an easy technology where you probably can't do a whole lot of bad. And antibiotic dosing should be much more easily studyable in that kind of a technology than high volume or high cutoff. So I would probably put my money on that technology and look for certain gaps to be filled in knowledge over the next probably few years.
Yeah, I totally agree with what Ramesh said. I think, we've slowly started moving towards using Oxiris more often than not, especially in septic patients. Not that, we don't perceive that clinical outcome immediately, but at least based on the available evidence, there is definitely a signal that Oxiris is the use of Oxiris is feasible with your regular CRRT machines, and clearly, there are some outcomes that are beneficial. So Yeah, I mean, we've started using it more often as of now, but for the rest of the therapies, clearly, it's an absolute no for now. It's more experimental or more used under research conditions. As to your question as to how RCTs can be designed, I mean, Tapas, I think there are a few things that needs to be understood when we talk about RCTs. I mean, of course, this is totally a gray area. And as I said earlier, we know theoretically these things can work, but it doesn't work in practice. So it's a question of, there are a lot of questions that will come up, and I'm sure, a single RCT may not be able to answer all this. And that's where, these RCTs fail. So to design an RCT, it's going to be very difficult. And I think, Sumit's
Yes.
suggestion that we should look at AI to pick up that phenotype and then start using it might be one way forward to choose or to be precise with your patient selection. I think once that aspect is sorted, then the timing and other things will also, need to be considered in RCTs. So it's not going to be easy to design RCTs, especially when your patient is at the brink of death and you're throwing the sink at the patient. So I think, in every such RCT, you would find that any device you have used is only a failure. And there have been only few things, that eventually have shown some benefits outside the septic world. But clearly, when you use it in patients in extremis, I don't think there are a lot of things in intensive care medicine that has shown big time benefits. So it's not going to be easy to design RCTs that way. I think it would be better to look back at our own data sets and experience and see if there is a signal towards a particular group of patients getting benefited, and then take it from there, design your RCTs from there.
I think, just so if you want to know would I use it right now? No, I would not. Also, I come from, my hospital is a place where cost becomes a very important factor. And I don't see really the signal right now to use it. But how do we do the study? I think like the Mimics-3 database is, I think it will require more than a clinical researcher to find the subgroup for the RCT. We will have to have data scientists, etc., to help us figure out which subset to look at it. If we do this study for all comers of sepsis, it is not going to work. I can guarantee that. That is something we can guarantee, that it is not going to work. So that is where we will actually, before we design the RCT, we will need the help of data scientists to choose. So anybody who's planning a study like that has to have a data scientist on board who can use the Mimics-3 data. That is, relatively the lowest hanging fruit in terms of, the data available. I'm not saying that it's easy, but, you need who can do that rather than, trying to get your own data. So the Mimics-3 database can be used, and you would need a data scientist. I don't know how to go about finding a good data scientist who would do that, but I'm just saying that would be necessary before we really think of how to design the RCT. And also industry has to also realize that in the process of trying to sell volumes, they will get negative studies if they don't find the subphenotype, or if there is a subphenotype to use it in. So that balance the industry has to also understand, that don't try to get it for everybody. In the process, you will get it for nobody.
So yeah, it's a never-ending discussion, I can say, at this point of time. But yes, hopefully we'll have some of the answers in near future. Yeah. So with this, I would request the panelists to just take few of the questions in the chat box. I think most of the things have already been discussed during this post-talk discussion only. How can we clinically determining the timing of using ECBP already discussed. Then what should be the guidance for giving antibiotics for patients undergoing ECBP? So is there any guidance or any guideline?
So the crude guidelines, right? We can't measure the drug level of every level possible. The current guidelines is after the therapy is over, give them an extra dose. I mean, it's just kind of a non-specific recommendation that I could see looking at the literature. If you're going to do a adsorption device for say 4 hours or 6 hours, just give a full dose right after that is over. And that's just a very primitive way of looking at it. But unfortunately, that's all practically we do at this point of time.
And there was another question about interleukin-6 blockers, I think.
Yes, sir.
Yeah, so that doesn't seem to have helped. Blockers of so there are two pathways that interleukin-6 works on. One is the antibacterial and the anti-inflammatory. I mean, the inflammatory and the baricitinib, etc., blocks the inflammatory without. So it helped in COVID, but the pattern of immune response in COVID is very different from the usual bacterial sepsis we are talking about here. So it has none of these interleukin blockers, pathway blockers have helped. And I sometimes tell this to my students that, oncology in some ways is easier because you have these pathways, you find these pathways to block, and you block one pathway and you get good results many a times. I'm not saying it becomes easier because of the kind of research which is done at a certain level of work. But for sepsis, unfortunately, the pathways are multiple. So blocking one pathway is not, as Ramesh said. The other is, I think this is unrelated to the pathways that Dr. Ramanathan spoke about, is should mortality be a whatever target for but it has to be, I think, for any disease process which has high mortality, whichever it is, reduction in mortality, I think, has to be a target in the eventual analysis. So that's my take on it. But I mean, that is obviously debatable, but I thought that I would put that into.
Yeah. So thank you, sir, for the lucid discussion, as well as enlightening all of us, including the panelists, as well as the audience here, the attendees. So if there are no more questions, I think we are just like 1 or 10 minutes discussion about this important concept, rather I would say. And thank you very much, Dr. Ramesh Venkatraman, for this excellent.
Thank you, Ramesh. Fantastic.
Thanks, Sumit. Thanks, Ramanathan. Nice.
Thank you. Nice meeting you.
Hooked up later. Thanks, Tapas. Thank you.
Yeah,
thank you.
And thank you all the
Thanks,
panelists.
Thanks, Anand. Jacob.
Thank you.
Thanks, Jacob. Bye-bye.
Yeah.
Thank you.
Bye-bye.
So we'll be now going ahead with our quiz. So I am sharing with all of you in the chat box the Google form link, and we'll have 8 minutes time to answer all these questions, and then we'll be showing the answers to the questions and the responses, the complete the scorecard, as well as the leaderboard, who scored the top 8 position or 10 position. Yeah. So I'm just sharing in the chat box. Everybody please attempt all the questions in 8 minutes from now.